Vikram?
Yeah, can you hear me, madam?
Yeah, I can hear you. Are you
I
ready?
have I have shared my screen also. Is it visible?
Yeah, it's visible. It is visible.
Okay.
आपण 11:05 ला चालू करूया.
काय?
We'll start at 11:05.
हो चालेल.
We'll wait for some more people to join.
चालेल. ह्याच्यात पण व्हिडिओ का दिसत नाहीये?
Hello? Yeah, Vikram. Hello?
Hello.
Yes, Vikram?
Should we start or wait?
Wait another 2 minutes.
There are only
11:05 ला
10
चालू करूया.
participants. Yeah, okay.
11:05 ला चालू करूया. Vikram, we'll start, okay? Vikram?
Yeah, I'm ready.
Yeah. So, good morning, everybody. Today we have another young, very talented rheumatologist with us today, and he's going to enlighten us on antiphospholipid antibody syndrome. Dr. Vikram Londhe is Associate Professor at HBT Medical College and R.N. Cooper Hospital. He also is a consultant rheumatologist at Criticare Super Specialty Hospital. Today he'll be speaking to us on antiphospholipid antibody syndrome. Over to you, Dr. Vikram.
Yeah, a very good morning to all of you. Now, antiphospholipid antibody syndrome, as the name suggests, the objectives of this session would be, at the end of this lecture, the PG students in medicine should be able to define antiphospholipid syndrome, should be able to enumerate clinical features of APS, describe the pathogenesis of antiphospholipid syndrome, should be able to enumerate the clinical features and enumerate the Sapporo classification criteria of 2006, describe the catastrophic antiphospholipid syndrome, differentiate other conditions from catastrophic APS, and treat the cases of antiphospholipid syndrome. So just a historical background of antiphospholipid syndrome. After the Second World War was over, in 1952, an unusual clotting inhibitor was described in patients of SLE, which was later on named as lupus anticoagulant. It was frequently associated with the biological false positive test for syphilis. In 1963, Bowie described that thrombosis is more common than the earlier descriptions of hemorrhage, which was described with lupus anticoagulant. In 1976, Johansson described a syndrome of recurrent thrombosis associated with this biologically false positive agent, which was testing positive for syphilis. Nielsen described spontaneous abortion associated with lupus anticoagulant. In 1980, the recurrent fetal loss, thrombosis, and LA association was established. And in 1983, Professor Graham Hughes and colleagues found that lupus anticoagulant is related to biologically false positive test for syphilis due to a negatively charged anticardiolipin antibody. The antigen was detected, and therefore this is also named as Hughes syndrome. So this was Professor Graham Hughes who described the complete description of this syndrome in 1983. So what is antiphospholipid antibody syndrome? It is an acquired autoimmune thrombophilia, which is characterized by vascular thrombosis, which could be arterial or venous, recurrent pregnancy losses, thrombocytopenia, and laboratory evidence for antibodies against the phospholipids or phospholipid binding protein cofactors in the blood. So as
Excuse me, sir. Can you make the screen view, big screen view? Yes, thank you, sir.
So if you see this figure, you can find out that there is a phosphate moiety which is attached to glycerol and the fatty acid change, and hence the name phospholipids. There are various domains of this phospholipid, whereby it can be attached to the carbohydrate side chain or it can be attached to the cell membrane, which has got a positive charge. So this beta 2 GPI has got a positive charge, and there is a negative charge which comes at the cell membrane, which we'll discuss during the pathogenesis. What is the epidemiology of this disease? 1 to 5% of healthy individuals can have antiphospholipid antibodies in low titers. There could be increase in the titers along with the age. 20 to 40% of the patients with SLE may harbor this antibody. In RA, this antibody may be present, but majority of the times, the patients do not develop the complete syndrome. In patients of SLE, 15 to 34% of the patients may have the lupus anticoagulant. Whereas 12 to 44% may have the anticardiolipin antibodies, 10 to 20% may have the anti-beta 2 GPI, and 20 to 50% may develop the thrombotic events. APS is also associated with other diseases like malignancy, particularly the hematological malignancies like B-cell lymphoma, CML, non-Hodgkin's lymphoma, renal cell carcinoma, CA breast, and adenocarcinoma. It is also having a strong association with autoimmune hypothyroidism. Next slide, please. The incidence of APL with frequency estimate is around 6% in pregnancy morbidity and mortality, 14% for stroke, 17% of younger thrombotic events are due to antiphospholipid syndrome, 11% for myocardial infarction, and 10% for DVT. So in a population of 100,000, the incidence is usually 3 to 4 for antiphospholipid syndrome. Now, these are the various studies which have been reported from the Indian authors in patients of young strokes or any thrombotic events, recurrent pregnancy loss, young MI, and stroke. And you will find that the prevalence in India also is in the range of about 18 to almost 50%. So what do these antibodies consist of? These antibodies are against phosphatidylcholine, phosphatidylethanolamine, phosphatidylserine, or phosphatidylglycerol. Anticardiolipin are directed against diphosphatidylglycerol, and antiphospholipid antibody is actually a misnomer. Why? Because there are antibodies which are detected against the protein phospholipid complexes and not just against the phospholipids. The newer targets which have now been recognized are prothrombin and annexin, which subsequently gave rise to the process of thrombosis. Now, there are certain other conditions where the patient will be positive for antiphospholipid antibodies, but they need not necessarily develop the full-fledged syndrome. So healthy individuals, so during blood donation, it was found out that when these patients who are healthy donors are screened for these antibodies, they turn out to be positive. As the age advances beyond 60, the incidence of positivity increases. Certain lymphoproliferative disorders, infectious mononucleosis, infectious conditions like syphilis, HIV, Lyme's disease, tuberculosis, leprosy, they all have B cell activation, which gives rise to antibody formation. And therefore, a positivity of antiphospholipids is seen with these infections. Just as we have drug-induced lupus, we also have drugs which will stimulate the formation of antiphospholipids like phenytoin sodium, hydralazine, valproate, phenothiazines, procainamide, and chlorpromazine. So one should remember that there are patients who may be harboring the antibody but may not develop the disease. And these are the conditions that are associated with positive antiphospholipid antibodies. So what is the pathogenesis? Now, antiphospholipid antibodies are both diagnostic markers as well as pathogenic drivers of this syndrome. So there is a first hit and a second hit theory which has been popularly accepted in the pathogenesis of antiphospholipid syndrome. During the first hit theory, in a genetically predisposed individual, whenever there is disruption of the endothelium, and why does this disruption of endothelium occur? It occurs during the activation or apoptosis of the endothelial cells, the platelets, and the trophoblasts. Phosphatidylserine, which is a negatively charged phospholipid, will migrate to the cell membrane. Now, this which is present deep inside the cell migrates to the cell membrane. The circulating beta-2 GPI binds to this phosphatidylserine via the surface receptors like ApoE2 or annexin A2 or toll-like receptors which form the beta-2 GPI antiphospholipid dimer. So this is the process of pathogenesis. You can see here that the beta-2 GPI, which had a positive charge, binds to the negatively charged phosphatidylserine at the level of the cell membrane. And this occurs with the help of APO2 receptors, annexin A2 receptors, or toll-like receptors, and thereby triggering the signaling of the P38 MAPK or NFK beta, that is your natural killer factor beta. And all this subsequently gives rise to complement activation, which induces the expression of adhesion molecules, activates monocytes and polymorphonuclear leukocytes, which release the pro-inflammatory mediators, which in turn cause the thrombotic state. There are other theories which have been proposed, like oxidation, which is mediated by vascular endothelium via the endothelial nitric oxide synthase, which leads to this leukocyte adhesion and thrombosis. Interference or modulation of the phospholipid binding protein is involved in regulation of the normal coagulation pathway. So, in an endothelium which is already disrupted, when there is a second hit in the form of infection or in the form of malignancy or inflammatory autoimmune conditions, it usually triggers the process of thrombosis by the mechanism which we just discussed. So during the second hit, there is complement activation, which causes and triggers the process of thrombosis. So during the first hit, your APL and the beta-2 GPI dimers will bind to each other. That will trigger, and when the second hit occurs, the endothelium, which is already disrupted, triggers the process of thrombosis by complement activation and further triggering the process of thrombosis. So the antiphospholipid syndrome criteria, which were laid down in 1999, were validated in the year 2000, which subsequently were revised in 2006 in the Sydney revision. So initially in 1999, it was proposed that the laboratory criteria, the test should be positive at the end of 6 weeks. This criteria was later on revised in 2006, and the test should be positive at 12 weeks interval. So what are these criteria? For calling the case of definite antiphospholipid syndrome, you should have one clinical criteria and one lab criteria. What are the clinical criteria? Vascular thrombosis, which could be arterial or venous, pregnancy morbidity, when there is one or more death of a normal fetus after 10 weeks of gestation, one or more premature birth at less than 34 weeks of gestation due to severe preeclampsia or placental insufficiency, or more than 3 consecutive abortions at less than 10 weeks gestation, with other causes being ruled out. The laboratory criteria are anticardiolipin antibodies positive for IgG or IgM, lupus anticoagulant positivity, and anti-beta-2 GPI, IgG, and IgM. In medium or higher titers, medium titers are considered as 40 and higher titers more than 60 at 12 weeks apart duration. So one must test the patient suspected for APS at 12 weeks duration with these titers positivity for confirming the diagnosis. There are certain other features which are not included in the clinical classification, but these suggest antiphospholipid syndrome. So they are livedo reticularis, thrombocytopenia, autoimmune hemolytic anemia, cardiac valve disease, and mitral valve valvopathy is the commonest that has been described. Multiple sclerosis-like syndrome, involuntary movement in the form of chorea, or other myelopathy. The laboratory criteria have now added IgA anticardiolipin antibody or IgA anti-beta-2 GPI. Now, initially in literature, it has been described that there are certain patients who fulfill the clinical criteria for APS, but laboratory-wise, they turn out to be negative for IgG and IgM, and they were labeled as seronegative APS. As research has progressed, it has now been clear that although IgG and IgM may be negative, they may be positive for IgA antibodies, and therefore these have been considered as features which suggest APS. And in those patients who were earlier labeled as seronegative APS, you should test for IgA antibodies. If that comes positive, you can label the patient as APS. Now, when one has a patient who is suffering from unexplained arterial thrombosis, it is very likely that anticardiolipin antibody may test positive, whereas venous thrombosis, it is usually the lupus anticoagulant. There are other conditions which can cause arterial thrombosis: atherosclerosis, vasculitis, homocystinemia and homocystinuria, myeloproliferative disorders, protein C, protein S, or antithrombin 3 deficiency can also give rise to arterial thrombosis. So particularly when you are evaluating the process of thrombosis in a young individual, apart from antiphospholipid syndrome, you must keep these differentials in mind. When you are evaluating a case of unexplained venous thrombosis, apart from antiphospholipid syndrome, you may be dealing with factor V Leiden mutation, protein C deficiency, protein S deficiency, antithrombin 3 deficiency, nephrotic syndrome, a peripartum state. Most of the times in the peripartum period, the patients may present with convulsions, cortical venous sinus thrombosis, which could be related to antiphospholipid syndrome or could be related to any of these conditions. Peripartum state by itself increases the risk of hypercoagulation. Females who are taking estrogen-containing oral contraceptive pills can have venous thrombosis. Malignancy-induced venous thrombosis, which is called as Trozos syndrome. Behçet syndrome can be associated with venous thrombosis, paroxysmal nocturnal hemoglobinuria, and heparin-induced thrombocytopenia. Now, when you have heparin-induced thrombocytopenia, the fall in the platelet is usually more than 50% of what it was at baseline before you start heparin. What are the clinical features that you can expect in patient of antiphospholipid syndrome? Cardiovascular conditions like myocardial infarction or cardiac valvulopathy. There could be thickening of the valve leaflets, which is mistaken for a rheumatic heart disease. The presentation is more or less similar. In cardiac rheumatic involvement, it is usually the tips which are involved, whereas in APS, it is the entire valve leaflet which is likely to be involved. The skin lesions that you see are livedo reticularis, leg ulcers, digital gangrene, pyoderma gangrenosum, or superficial skin necrosis. This is how livedo reticularis will look like. There will be mosaic pattern which is present on the thighs or on the legs. There could be dusky fingertips in the form of pregangrenous changes, or there may be frank digital gangrene, which is a dry gangrene. Obstetrics, the involvement is spontaneous abortion. There could be preeclampsia, eclampsia, intrauterine growth retardation or intrauterine fetal death, placental insufficiency. Neurologically, the patient may present with cerebrovascular accident, which could be thrombotic, embolic, or may present with cortical venous sinus thrombosis, refractory headache, migrainous episodes, epilepsy, chorea, and longitudinally extensive transverse myelitis. So patients presenting with hemiplegia or paraplegia, when you don't get a clear-cut cause, you must think of antiphospholipid syndrome. The patient may present with retinal arteritis, sudden onset, loss of vision, retinal venous occlusion, ischemic optic neuropathy, or sudden onset unilateral blindness, that is amaurosis fugax. The patient may present with hemolytic anemia, thrombocytopenia, thrombotic microangiopathy. In the kidneys, there could be severe hypertension due to renovascular microangiopathy or renal failure. Patients of pulmonary embolism, pulmonary hypertension, or pulmonary hemorrhage should also be evaluated for antiphospholipid syndrome. Commonest presentation can be deep vein thrombosis, which leads to pulmonary embolism. So the imaging in CVST will show you the filling defect. Now in this photograph, you can see that there is a left transverse sinus filling defect. The right transverse sinus is clearly filling, and there is a low flow signal in the straight sinus. Now, having understood the clinical features of antiphospholipid syndrome, you must know that there is something called as catastrophic antiphospholipid syndrome, which is one of the rheumatological emergencies. The patient can present with multi-organ failure, which can be precipitated either by stoppage of anticoagulation, triggered by infection, triggered by the surgical stress, or by consumption of OC pills. The differentials for catastrophic APS are sepsis, disseminated intravascular coagulation, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, malignancy-related thrombosis, vasculitis, infective endocarditis, hyperhomocystinemia, and factor V Leiden mutation. These are the commonest closest differentials. DIC, TTP, sepsis, and CAPS will have very close differentials. The treatment of catastrophic APS is anticoagulation, steroids, IVIG, plasmapheresis. Rituximab and eculizumab can also be tried in cases of catastrophic APS. Now, these are the Asherson's criteria for catastrophic APS. So when do you diagnose or how do you label it as catastrophic APS? There is evidence of involvement of 3 or more organs or systems or tissues which occur within a week of each other. So the development of the clinical features should occur simultaneously or at the most in a span of 1 week duration. There is confirmation by histopathology of small vessel occlusion in at least one organ or tissue, laboratory confirmation of the presence of lupus anticoagulant, anticardiolipin, or beta-2 GPI antibodies. Now, when all 4 criteria are present, you call it as definite catastrophic APS. It is called as probable catastrophic APS when the criteria 2 to 4 are fulfilled. When criteria 1 to 3 are fulfilled, it is again probable. Criteria 1, 2, and 4 are fulfilled, it is probable. Criteria 1, 3, and 4, and 1, 3, and 4 should occur in more than 1 week duration, but less than 1 month. Then you call it as catastrophic APS. So what are the clinical features of catastrophic APS? There could be cerebrovascular accident, just as you get with APS. You can have cortical venous sinus thrombosis, longitudinally extensive transverse myelitis. Most of the ophthalmic features will come as presentation of CAPS, renal vein thrombosis, renal thrombotic microangiopathy, endothelial damage of the glomerular capillaries, which presents as acute glomerulonephritis, Budd-Chiari syndrome, thrombosis of the hepatic veins, IUGR, HELP syndrome or placental infarction in a pregnant female, gut infarction or peripheral gangrene. So when 3 or more of these organs come together, you will call it as catastrophic APS. So as I discussed earlier, the differentials of catastrophic APS are thrombotic thrombocytopenic purpura and DIC. So how do you differentiate one from the other? Microangiopathic hemolytic anemia will be present in TTP and DIC, which will not be seen in catastrophic APS. Thrombocytopenia will be a common feature to all of them. DIC will have decreased levels of fibrinogen, whereas the fibrinogen degradation products will be increased in DIC and TTP, but will be normal in catastrophic APS. Anticardiolipin antibody and or lupus anticoagulant or beta-2 GPI will be positive in catastrophic APS, whereas in TTP and DIC, these antibodies will be absent. So that is how, although clinical features will be more or less similar, these lab features will help in differentiating catastrophic APS from TTP and DIC. Now, based on the classification for antiphospholipid syndrome, it is classified as primary or secondary. When you do not have any other underlying disease, you call it as primary. And when you have other connective tissue disorder associated with it, you call it as secondary. The commonest association being with SLE, scleroderma, and Sjogren's syndrome. And amongst them, most common is SLE. Based on the organ involvement or arterial and venous, APS has also been described by certain researchers as type 1, which consists of retinal, CNS, or major organ involvement, type 2, which is arterial thrombosis, type 3, which is venous thrombosis, type 4 is arterial as well as venous thrombosis, type 5 is obstetrical involvement, and type 6 is asymptomatic patients who have only antibody positivity. Whether they will develop the syndrome or not, we do not know. Now, having understood the pathogenesis, clinical features, we should know how to investigate or how to approach the case of antiphospholipid syndrome. You should do the baseline hemoglobin, CBC, and ESR, anti-nuclear antibody to decide whether it is a primary APS or a secondary APS based on the clinical features, not just on the lab parameters. Anticardiolipin antibody, IgG, IgM, lupus anticoagulant, beta-2 GPI, IgG, and IgM. And when there is a strong suspicion, if ACL, lupus anticoagulant, and beta-2 GPI are negative for IgG and IgM, you can ask for IgA. Prothrombin time and INR, because you want to put the patients on anticoagulants. 2D echo to rule out infective endocarditis, as well as to check whether there is valvulopathy, which is a criteria of APS, not in the classification criteria, but the other criteria. Ultrasound of the obstetrics and Doppler to see for the fetal circulation and the placental circulation. Relevant CT scans with arterial or venous angiography, depending on whether you are dealing with cortical venous sinus thrombosis, or you are dealing with Budd-Chiari syndrome, or you are suspecting a renal vein thrombosis. Urine examination for active urinary sediment, and fundoscopy if the patient is having acute onset blindness. Now, what are the treatment criteria or recommendation for treatment? Because ultimately, after diagnosing, we need to treat the patient. Asymptomatic patients who are incidentally detected to be positive for the antibodies, no treatment is recommended as of now. However, if it is a female patient who is going to plan a pregnancy, low dose aspirin 75 milligrams per day is recommended. If there is venous thrombosis, the patient should be started on vitamin K antagonist warfarin, and the INR ratio should be maintained between 2 to 3, an average of 2.5 indefinitely. If it is an arterial thrombosis, the treatment is same as venous thrombosis. If the patient has history of recurrent thrombosis, then warfarin should be given in a higher dose to maintain the INR between 3 to 4. Again, there are certain trials which have compared low INR 3 to 4, low INR between 2 to 3 versus high INR between 3 to 4, and it has been found that low INR between 2 to 3 can be equally effective provided you add a low dose aspirin along with it. Then there is no need to maintain the INR between 3 to 4, because the chances of warfarin toxicity increases with the INR between 3 to 4. So it is better to give warfarin in the best possible dose to maintain the INR between 2 to 3 and add a low dose aspirin. If the person has valve nodules or deformity of the valve, there is no known effective treatment. Full anticoagulation is recommended if there are intracardiac thrombi or if you are suspecting embolization. If there is thrombocytopenia and the platelets are more than 50,000, no treatment is recommended. Now, when you are dealing with an obstetric case who has got one or more than one fetal loss or 3 or more than 3 pre-embryonic losses, but there is no history of prior thrombosis, the patient has tested positive for the antiphospholipid antibodies, but there is no underlying SLE, you start the patient on prophylactic low molecular weight heparin, 0.5 milligram per kilogram per day, with a low dose aspirin 75 milligram per day throughout the pregnancy, and for 6 to 12 weeks in the postpartum period, because the postpartum period is also an equal risk for development of thrombosis. If there is more than one fetal loss or more than 3 pre-embryonic losses, there is no prior history of thrombosis, but the patient has got antiphospholipid syndrome along with SLE, the treatment would remain the same as discussed earlier, plus prednisolone and hydroxychloroquine should be added for controlling the lupus. Because during pregnancy, it is not just necessary that because you are antiphospholipid syndrome, your syndrome is active and a pregnancy loss is because of that. It could be the flare of lupus. Patient may present with preeclampsia, patient may present with high ESR, high CRP, and there is rise in the blood pressure. So when the patient has got active urinary sediment along with high BP, progressive renal failure which occurs during pregnancy, think of flare of SLE also, and the patient will require higher doses of methylprednisolone during pregnancy to control the lupus flare. Once the lupus flare is controlled, the pregnancy can be carried till full term. Next scenario is prior history of thrombosis, regardless of pregnancy loss, antiphospholipid syndrome, but no SLE. Treat with therapeutic doses of low molecular weight heparin, 1.5 mg per kg per day, or 1 mg per kg twice a day with low dose aspirin throughout the pregnancy and in the postpartum period, and add warfarin after 12 weeks of postpartum period. Next scenario is prior history of thrombosis, regardless of pregnancy loss. Patient is having SLE with antiphospholipid syndrome. You treat as above. You give low molecular weight heparin, low dose aspirin, prednisolone, hydroxychloroquine, and warfarin after 12 weeks. If the patient presents with thrombocytopenia and platelets are less than 50,000, you may have to give prednisolone, and if it is a life-threatening situation, you may have to give IVIG. Catastrophic APS requires anticoagulation, corticosteroids, IVIG or plasmapheresis, and rituximab or eculizumab can be equally effective in catastrophic APS. Now, when the patient has got only antibody positivity, there is no thrombosis or no SLE, low dose aspirin throughout pregnancy is what is recommended. Now, let us see few cases where the patients have been treated. But before that, just remember that antiphospholipid syndrome is not synonymous with positivity for antiphospholipid antibodies. Presence of antiphospholipid antibodies alone in the absence of clinical manifestation does not always mandate therapy. If all the three are positive, like anticardiolipin antibody, lupus anticoagulant, and anti-beta 2 GPI, triple positivity increases the risk of thrombosis as well as in a pregnant patient, pregnancy morbidity. So let us see how you should treat or apply your knowledge in treatment of the cases after listening to this lecture. A 24-year-old female was referred from a gynecologist in view of recurrent abortions. She had 3 spontaneous abortions in Jan 21, October 22, and March 23. There was no history suggestive of SLE or no past history of thrombosis. She did not have any pedal edema, puffiness of face, oliguria, psychosis, altered sensorium, muscle weakness, or features of neuropathy. There was no history of thyroid dysfunction. Menstrual history was regular. On examination, there was no systemic abnormality. Vitals were normal, and general examination did not reveal any abnormality. On investigations, her ESR was 20, TOR screen and CRP was negative. She was negative for ANA, but she was positive for anticardiolipin antibodies, IgM 34.5. And after 12 weeks, it was more than 20. Anticardiolipin IgG was 54.9. Lupus anticoagulant was negative. Anti-beta 2 GPI was negative. So this patient also had positive IgM and IgG titers at the end of 12 weeks. So she fulfilled the clinical criteria as well as the lab criteria. So she was started on aspirin. Now, during this time, she conceived again and was treated with low-dose aspirin and low molecular weight heparin throughout the pregnancy, and she had a normal pregnancy outcome. The second case, presented with 2 months of amenorrhea, was referred for opinion and further management in view of lupus anticoagulant positivity, IgM and IgG anticardiolipin positivity. She did have a past history of a thrombotic event in the form of cortical venous sinus thrombosis, which was treated by a neurologist for 6 months with low molecular weight heparin as well as warfarin. So in view of this significant past history, she was treated with aspirin, enoxaparin twice a day throughout the pregnancy. But in spite of this, she developed a fetal demise at 6 months of gestation. So there is poor obstetric outcome in patients who have a past history of thrombosis. So the patient has to be counseled before conception that although the chances of pregnancy outcome may improve with low-dose aspirin and low molecular weight heparin, there is no guarantee that the pregnancy outcome will always be favorable. The third case was a 25-year-old female who was an engineer by profession, and she presented for opinion about planning a pregnancy back in March 2015. She was a diagnosed case of SLE in 2012 and was being treated with hydroxychloroquine and prednisolone. Her lupus was in remission. In 2013, she got married and went to the Middle East, and so she had lots to follow up. During this period, her ANA was positive, 1 in 1000 homogeneous pattern, dsDNA was negative, and her anticardiolipin antibodies beta-2 GPI lupus anticoagulant was absent. In 2014, she conceived and was receiving hydroxychloroquine and prednisolone, but had a spontaneous abortion at 3 months of amenorrhea. This time, she tested positive for anticardiolipin antibodies in low titers. She was advised to start aspirin and hydroxychloroquine along with steroids. In 2015, she came up with a UPT positivity, and a pregnancy was confirmed for 6 weeks of gestation. She was added with low molecular weight heparin to the above regimen consisting of aspirin and hydroxychloroquine along with steroids. In November 2015, she developed pedal edema, rise in the BP, 24 hours urine protein increased to 1.5 grams with an active urinary sediment, and her complements had dropped. So this confirmed that there was a flare of the lupus, and therefore her steroids were stepped up to 1 milligram per kilogram per day. She was added on nifedipine and methyl dopa to control her BP, and she was being monitored every 15 days. In December, she developed a intrauterine growth retardation with oligohydramnios. She responded to the rise in steroids, and gradually the BP was controlled. The proteinuria was controlled. Her lupus activity got controlled, and at 36 weeks of gestation, she had a planned LSCS. So heparin and aspirin were stopped for 24 and 72 hours respectively prior to the LSCS, and accordingly, she delivered a male child of 2.3 kg. The LSCS was uneventful. Aspirin and heparin was restarted and continued for 6 weeks in the postpartum period. So, based on this case-based discussion and the earlier pathogenesis, clinical features, and treatment, I would like to re-emphasize that the term antiphospholipid syndrome is not synonymous with the presence of antiphospholipid antibodies. You may have the antibodies, which could be positive in healthy individuals, in advanced age, patients taking certain medications, or with certain infections or lymphoproliferative disorders. In the pathogenesis, the points to be remembered are the first hit theory, which causes endothelial disruption, followed by a second hit theory in which there is a process of thrombosis. Antiphospholipid syndrome can be primary or secondary when it is associated with underlying lupus or other connective tissue disorders, or thrombosis or malignancy or lymphoproliferative disorders. Catastrophic APS is a rheumatological emergency which needs to be treated aggressively. While treating a pregnant patient with APS, you should try to evaluate whether there is a flare of underlying lupus or other connective tissue disorder, and the treatment has to be optimized to control the lupus flare or the other connective tissue disease flare. Then you may have a good outcome for the pregnancy. Interpretation of antiphospholipid reports should always be in the clinical setting, because you want to treat the patient as a whole and not just the lab reports. Thank you very much for a patient hearing. I'll be happy to take if there are questions, if any.
Thank you, Dr. Vikram. Very nice. In fact, what all you said in your slides, you actually demonstrated in your cases also. Any questions from the audience? Dr. Vikram, I have one question.
Yeah, madam.
Suppose you have a patient who is ANA positive, a diagnosed case of SLE. Would you screen all SLE patients for antiphospholipid antibody syndrome? I mean, antiphospholipid antibody associated disease, or there is a particular class of patients whom you would see, because these are expensive tests,
Yeah, so madam, in those patients who have a prior history of thrombosis, it is mandatory to test when they test positive for lupus. In other patients who have unexplained features, like some of the patients of lupus may present with pulmonary hypertension or unexplained pulmonary hemorrhages. In those patients, it will be mandatory to check.
Even
Third,
unexplained thrombocytopenia, no?
Even unexplained thrombocytopenia. The third scenario will be a case of lupus who is planning a pregnancy. And if there are any of these, like if there is thrombocytopenia or if she has had a prior fetal loss, then it would become mandatory to test these.
But even if such history is not available, any patient, any young female with lupus who is planning a pregnancy,
she should be checked for it. Yes,
we would always. Then is it necessary to do all the 3 tests, or just doing anticardiolipin antibody would be sufficient? If there is no history,
if there is no prior history, then as a screening test, lupus anticoagulant will be recommended when there is thrombocytopenia.
You would recommend lupus anticoagulant?
When there is thrombocytopenia. When there is no thrombocytopenia, anticardiolipin antibody may be sufficient. So there is no need to check all the 3. But if there is a slightest risk, then all 3 should be checked.
When we order the test, some people write anticardiolipin antibody or antiphospholipid antibody. What should we order actually?
It should be ordered as anticardiolipin antibody, IgG and IgM, lupus anticoagulant, and anti-beta 2 GPI, IgG and IgM. Because there is no single test which will test the antiphospholipid antibodies. As I said earlier, antiphospholipid antibody is actually a misnomer. These are the antibodies against the APS with the protein primer, which forms a dimer. So there is nothing called as antiphospholipid antibodies which can be tested directly. You should always ask for 3 separate entities.
Okay. So is there any role for steroids in patients who are lupus with APLA positive and having a thrombotic episode? But the lupus is quiet, the complements are normal.
Yeah, even if the complements are normal and lupus is quiescent, a low dose maintenance steroid of 5 or 7.5 milligrams is recommended, because the process of thrombosis in APS usually gets triggered by an inflammatory event or an infection. And patients of lupus, they may be having a low disease activity where the complements may be normal, thrombocytopenia may not be detected. So in a patient of lupus, not only steroids, but hydroxychloroquine should also be given when there is a APS with it.
Okay, do we get some clue from the PTT whether we should screen a patient for antiphospholipid antibody?
Yeah, if the APTT is prolonged, it usually can be a marker. So lupus anticoagulant should be the first one which could be tested, or you can do a VDRL also, because there is biologically false positive test for syphilis. So as a screening test, VDRL, APTT can be done. And if there is an abnormality in that, then you can go ahead with all the 3 tests.
So there's a question on the chat. Do we need to monitor for adverse effects of HCQS in pregnancy?
Do we need to monitor the?
Monitor for adverse effects of HCQS in pregnancy.
The adverse effects of HCQS would not occur immediately during the pregnancy, because if the patient has been receiving it for less than 1 year, then there are less chances, because bullseye maculopathy is the one which is likely to occur. The patient may develop gastritis, which can cause vomiting. So apart from that, just pigmentation, which can occur either as a part of pregnancy or as a part of hydroxychloroquine. So there is no need to monitor it during pregnancy. If the patient has been taking hydroxychloroquine for more than 1 year, then it would be better to do a baseline fundoscopy just to rule out that there is no toxicity that is being developed in the eye. And also with hydroxychloroquine, the chances are much, much less as compared to what we were seeing earlier when chloroquine was being used.
Generally, I see a lot of gynecologists, ANA positive, they will start aspirin. ANA positive, they start low molecular weight heparin also without investigating for antiphospholipid. So what would be the side effects of, if suppose heparin is not indicated and is given through pregnancy?
Yeah, heparin can induce bleeding, heparin can induce thrombocytopenia. So heparin-induced thrombocytopenia will add to the confusion whether the patient is really developing a syndrome related to lupus because the patient is ANA positive, or is the patient developing APS because of the fall in the platelets. So heparin would not be recommended just because the patient is ANA positive in the absence of clinical features of any connective tissue disorder. So the patient should be referred to a rheumatologist for evaluation clinically whether that ANA positivity has got any meaning or not. Suppose if this patient who has become pregnant now has a past history of tuberculosis, has received isoniazid, or has been having past history of convulsions for which she has received phenytoin or carbamazepine, these drugs can test positive for ANA. So only lab positivity does not translate into the clinical disease. So the patient should always be evaluated clinically, and then a decision about heparin should be taken. Low dose aspirin can be given, there is no problem about it. But as far as low molecular weight heparin or conventional heparin is given, it should always be based on the clinical features, not just on lab positivity.
Right. Because we see patients, one pregnancy loss and the gynecologist treats next time with low molecular weight heparin and aspirin. And suppose that goes to full term, then they make it a dictum, that every pregnancy loss we have to give this. That is how they sometimes follow the protocol.
Yeah, because if we go by the definition, the pregnancy losses or the embryonic losses which are less than 10 weeks of gestation are usually because of some genetic abnormalities or chromosomal abnormalities. So there is no role of aspirin or heparin.
Okay, there's one more question on the chat. What are clinical clues to start suspecting catastrophic APS in patients with no history of thrombosis?
Yeah, so when there is simultaneous occurrence of 3 or more than 3 organs, tissues, that is the time when you should suspect. Within a week's time, the patient is just going downhill. So that time you have to suspect catastrophic APS. It could be a neurological involvement, it could be ophthalmic involvement, it could be a pregnant patient who is developing that, there could be sudden onset renal failure, there could be monoocular blindness, thrombocytopenia. So any of these which are occurring within 1 week's duration, then you must suspect a catastrophic APS.
Because it's a very aggressive manifestation. I mean, it hardly gives you any time. It's just one after the other. There's one more question. Can pregnant patients present with HELLP syndrome if applies positive?
Yeah, pregnant patients can present with HELLP syndrome if applies positive. There can be an overlap between the two.
Okay. Any further questions? Okay. I think, Vikram, you have cleared all our doubts. And Dr. Vikram, it was an excellent talk. And we are so thankful to you for taking out your time on a Sunday morning and give us this talk. Thank you so much.
Thank you, madam.
Thank you. Thank you to all the students. One point I would like to say, when you ask for ANA, I would again tell the postgraduates that please mention ANA by immunofluorescence. Just take that little trouble to write by IF, because many times you have ANA by ELISA, false positive, and patients are falsely diagnosed as lupus. So be very particular when you order for ANA and put it by immunofluorescence. That is mandatory. Okay. Thank you. Thank you everybody for attending. Thank you so much.